Hello everyone, Nick here again with another video. Second one in a day. I'm pretty proud of myself. And today we're going to be talking about pathopsychology, which is basically when things go wrong with your psychology. And today's topic is going to be depression. Once again, my email below, complexprep2k16@gmail.com. Email me with any questions, suggestions, concerns, what have you. Now let's begin. I'm going to start with this picture. I looked up, free pictures to use for your YouTube videos pretty much, and here we got this guy, and he obviously looks very depressed. And I'm going to create a little scenario for you. Hopefully it's going to help you remember depression. I'm going to call this guy John. And as you can see, John's hair is a little disheveled. His hand is up against his face. He's resting his face in his hand. And let's just say, he's been having trouble sleeping. He's lost his appetite. He's been having some erectile dysfunction. He's not able to, enjoy sexual relations with his beloved wife. He isn't finding pleasure in the things he is doing anymore. He used to like to run, and now he hardly ever runs. And that's kind of a clinical picture of depression, but it can be a lot of different things. It doesn't have to be just a sad person. Maybe it's someone who's having trouble sleeping and trouble eating. And so there's a wide variety of presentations, but let's just remember this patient, and hopefully that helps you remember depression overall. So what we need to know, unfortunately I don't have all this stuff on this presentation, but basically for anything that can go wrong, these are the things you need to know. Etiology, who it affects, whether it's young or old, male or female, Caucasian or African American or Asian descent, that kind of thing. Prognosis, what happens when you get the diagnosis? Do you die 2 days later, or do you live a relatively normal life? And other comorbid conditions. So with depression, anxiety disorder is common, and same with substance abuse. So it's important for you to keep these connections. Signs and symptoms, how is this patient going to present to you in the clinic or the hospital? The workup, what you're going to do when the patient comes in. And treatment, lastly treatment, what can you do to help this patient? And that's obviously very important. So let's get on with it. Depression. This is the slide that you need to memorize for depression. This is how you need to keep it organized in your head. There's major depressive symptoms, and there's 9 of them. Decreased mood, decreased concentration, withdrawal, irritability, negativity, psychomotor, agitation, or retardation. You're sped up or you're slowed down, and I think retardation is more common. Suicidal ideation, thoughts of suicide. Sleep changes. I think most people sleep less with insomnia and early morning waking, but there are types where you require more sleep, and appetite changes. So those are the 9 symptoms. You need 5 of the 9 symptoms present for at least 2 weeks to be diagnosed with depression. You need to memorize that. Write it down, say it 10 times, do whatever you need to do. Other things that it's important to keep in mind, you need to ask about sexual dysfunction. And the reason you need to ask that is it can be caused by depression or by certain medications you prescribe for depression. So if someone's depressed and they don't have sexual dysfunction, and then you put them on medication and they do, it's important to understand that so you can adjust the medication and correct that issue. And anhedonia, that basically means loss of interest or pleasure. And our patient had that. He liked to go for runs, and that no longer, he just stopped doing that, and it causes behavior modifications. So there's a few different types of suicidal ideation, and it's important for you to understand the differences. Passive, that's someone who thinks about dying but not about killing themselves. So they wouldn't mind if they got struck by lightning or got hit by a bus, and maybe the world would be better without them, but they're not going to kill themselves. Active, they think about killing themselves, them killing themselves. So that's how it's different from passive. Maybe they're thinking about hanging themselves, or maybe it's even more general, I'm just thinking about killing myself. Impulsive, a little different. You failed your exam, or maybe you broke up with your significant other, and you run upstairs, lock yourself in your room, and decide to take a bunch of ibuprofen or something. And so it's really spur of the moment. And then lastly, well thought out. This person has a plan, and they're very calm and matter of fact about it. They're just, I'm gonna, Thursday I'm gonna go into the garage and leave my car on and keep the garage door shut, and that's how I'm gonna do it. So there's a bunch of different types of suicidal ideation, and the well thought out are the ones that have the high risk of carrying it out. And when you think about it and you have time to plan, you can be more lethal. So that's important. Always ask 100% of your patients about suicidal ideation, thoughts of suicide, because, not every person with depression has suicidal ideation, and people can have suicidal ideation without depression. So it's a good screening tool. Obviously not everyone's going to say they do, but the few people you pick up with this question, do you ever have thoughts of suicide? You can save their life, and that's huge. So ask. So let's go over the other depressive disorders. Persistent depressive disorder. That's a depressed mood most of the day, more days than not, for 2 years. So pretty much most of the time for 2 years you're depressed. And it's prevalent in about 3 to 5% of the population and more common in women. I'm sorry I don't have more statistics like that, but feel free to look them up on your own. Premenstrual dysphoric disorder, PMDD. I'll just say PMDD because I clearly can't talk. 5 symptoms in the final week before onset of menses, and they become minimal or absent in the week after menses. So this depressive disorder basically orbits around a woman's menstrual cycle. Substance or medication-induced depressive disorder. Alcohol is a CNS depressant, and if you drink a lot, you might be suffering from depression, or you might be causing substance-induced depressive disorder. So you need to be able to tease those apart clinically. I'm not going to really go into more detail. Disrupted mood dysregulation disorder, another one to keep in mind. I'm not going to talk about it in this lecture. Dysthymic disorder. This is a less severe, it's less severe than major depressive disorder. You have no suicidal ideation, no psychomotor skills, and it's 2 years of a depressed mood. And you don't really have symptomatic episodes, and you kind of wax and wane. That's dysthymic disorder. Now, once you have your actual disorder, you can add specifiers. You add these onto the diagnosis. Anxious distress, mixed features, melancholic features, catatonia. You add these onto your diagnosis of major depressive disorder, or PMDD. And it allows you to be more specific, and that can guide treatment or help other healthcare professionals. Now remember, bipolar disorder has periods where a patient is depressed. So anxiety is closely related with disorder, depression, same with schizophrenia, same with bipolar disorder. You'll have a bipolar patient come in and they're in a depressed state, and that's because they're bipolar, but you might not know that. So it's important to understand that depression can be added onto a lot of other medical issues. Did you know depression is a chronic condition? Not a lot of people think of it that way. A lot of people just, think of it as depression. But it's a chronic disease. And over the time of the disease, there's an increase in frequency, duration, and severity of your depressive episodes. And so it's important to keep that in mind. So the longer you live with it, the worse it gets. And depression can be very lethal. 10% or more of depressed patients commit suicide over a lifetime. 10% of depressed patients are dying. And it's a very prevalent disease, so that should be a very scary statistic to you. Relapse rate, if you have one depressed episode, there's a 50% chance of it happening again. Two episodes, 75% chance of it happening again. And 3 episodes, 95% chance. So it's almost inevitable that you're going to have another depressive episode, and this really guides treatment. Unfortunately, a portion of patients are left unremitted. So about 30% are resistant to treatment, and unfortunately can't really be helped. And this is more pertaining to pharmacology in that realm. But it's sad that we can't help them. And then the average episode lasts about 9 months. And that's important to remember because that's going to guide how long you treat people. And same with the relapse rate, that's going to guide your treatment as well. So here's your workup. It's nothing special. Your depressed patient presents to you in the clinic and you order a CBC, thyroid. Occasionally you'll get someone hypothyroid, and that might be causing some or all of their symptoms, but that's pretty rare. Metabolic profile, family history, it runs in the family like pretty much everything. You got to ask about substance abuse and figure that out. Medical history and family and social issues. If a patient, their mom died, they got laid off from work, and they got diagnosed with cancer, I would be surprised if they weren't depressed. And so it's important to know this. Or if a patient was in an abusive relationship, you could throw as many antidepressants as you want, but if they're still being abused, how much is it going to help? I don't really know. So treatment, this is pretty limited right now. I think what's important is to understand that there's a lot of different treatments, and the way my lecturer described it to me is that as far as the SSRIs, and those are the most commonly used, there's a ton of them. Basically, they're all very effective. It's just about mitigating symptoms of your patient. So you use a combination of cognitive behavioral therapy and an antidepressant. And if the patient doesn't have insurance, unfortunately, they're probably just going to get the prescription. But fortunately, these prescriptions work pretty well. Mental ideation with SSRIs. This is like a black box warning. I'm sure you've heard a drug commercial. It says, may increase the risk of suicidal thoughts. And it's just something that you're going to have to explain. You have to tell your patients, and you're going to have to explain it to them. A meta-analysis showed a 2% increase in children and adolescents for suicidal ideation. Just suicidal thoughts. Only 2% in basically one age group. No increase in suicidal attempts or suicides. So it's important to understand that it's a risk-benefit analysis, but these drugs work and they prevent suicides. And it's better to have them and monitor for the suicidal ideation than not have them and be at risk for suicide. So the length of 1 year for first episode, then reevaluate. That's speaking about the treatment. And you have one episode, you get put on the antidepressant for a year, and then most people are taken off and see if it comes back. Now, if you've had your third episode, you're probably just going to be on antidepressants for the rest of your life because the episode's going to come back. And then remember to treat with a single agent, so just one drug, and treat long enough. If you're only treating them for 6 months, they might still have 3 more months of depression, or they might even have longer. So take the time, treat the patient, and then reassess. Depression and childbirth, those are something that's an association right there that you should keep in mind. Depression with peripartum onset. Symptoms are essentially the same as major depressive disorder, and it's important to screen after childbirth to make sure that your patient doesn't have this. And then there's such thing as postpartum psychosis, confusion and disorientation, hallucinations and delusions, paranoia, attempts to harm self or baby. This is very bad, and it's important to just keep this in the back of your mind that after childbirth, a certain portion of the female population can go through this, and it's important to keep them and their child safe. It'd be terrible if anything happened to them or their kid. So make sure you keep these in mind. So that pretty much sums up my depression video. Hopefully you guys liked it. I know I have a lot more work to do on my lecturing and putting together these PowerPoints. Things to come for pathopsychology. I want to have more pathology, obviously. There's more disorders to cover. I think a vocab lecture would be helpful because there's a lot of different terms that come up a lot, and I could go over those with you guys. There will be a pharm lecture. There's going to be a lot of pharm for sure, and then I'd like to do a board style review. a board style question review where I basically go through my Q bank and then make a few of my own questions and try and get at the topics that are being tested on, and try and help you prepare and get an idea of what some of those questions will be like. So once again, please email me with any of your suggestions. And if you watch this video, you're probably the first person, so I really appreciate it. So that is the end, and one last thing, the image credit goes out to pixabay.com. That's where I got our depressed patient, and it's going to be the thumbnail as well. So thank you guys so much for watching, and that concludes my depression video. What's up, guys? Thank you for watching. I just had to add a quick edit in. As you guys probably noticed, I did this presentation on a Google Doc or a Google Drive. So that's attached to my email complex, prep2k16@gmail.com. Hopefully that'll be public and available to you guys. I'll put a link in the description below. If you guys have any issues accessing it, just send me an email. I really appreciate you guys watching, and hopefully I can continue making good videos for you guys. Thank you once again.